Brad, can we get a quick
Question?
intro of, yeah, just quick intro of Manish and Rebecca. Just
No, that's what we're going to do. Yeah, that's what we're doing now.
Yeah.
Yeah. Okay. So I'm Brad Power, and I'm the co-founder with Brian here, who's here, of the Cancer Patient Lab. And today we'll be honored to be speaking with Manish Agrawal and Rebecca Ehrenkranz. I'll introduce them more in a moment. First, the disclaimers. There are two, which everyone who's a regular will know. Hi, Rick. And that is, this is not medical advice. This is information which you can use to educate yourself and engage with your medical team with options and ideas that you can bring to them in your care. And secondly, this will be made public. So everything you say will be made public. And if you're concerned about conserving your privacy, don't include your name on the or a picture and don't say anything. Otherwise, everything you say will be made public, and this recording will be also made public. So we're honored today to have Manish Agrawal and Rebecca Ehrenkranz with us. We've been searching for some time to find some subject matter experts to help us with understanding the use of psychedelics to deal with primarily, for me, it's called fear of mortality. Another name is anxiety concerns and existence anxiety, I guess you might call it. And through connections with our friend Tom Smith, who presented before from Johns Hopkins, who does the palliative care, he connected us with people who connected us with people who connected us with Manish and Rebecca. Rebecca's at Johns Hopkins. I'm sure they'll introduce themselves. She's in a lab that does experimentation or research on psychedelics and their effects. And Manish will introduce himself. He has a startup that is working in the same area and also has an academic background and a lot of research. Because we are a patient-centered and patient-led community, we wanted to start with a couple of patient cases, patient stories that can be a reference point for the research as we hear from Manish and Rebecca. And so Robert Ellis and Jeff Krolick have graciously offered to kind of share their experiences with psychedelics as a kind of a starting point. And then we'll switch to Manish and Rebecca. They'll talk for 5 or 10 minutes, and then we'll open it up for conversation. So with that, I'll turn it over to Robert Ellis.
Yeah. Thanks, Brad. Yeah, I can speak to my experience with ketamine in particular. In August of 2021, I was really struggling with how to deal with the progression of my disease and the uncertainty about how much time I had. And so I was experiencing some existential anxiety, I think you could say. I did ketamine through a company called MindBloom, which does remote medicine. So you have a consultation with a physician who looks at your medical records and makes sure that it's safe for you to do ketamine. They give you a prescription, they send you the medicine, and then there's a guide who talks to you before you do your session to make sure that you have a sitter with you. So my wife sat for me. And then after the session, they kind of debrief it. They do that for a couple of sessions, and then you learn how to use the medicine, and then you do sessions on your own. So I did a series of, I think, 6 sessions about a week apart, and with increasing doses. So the instructions that they give you are to hold these are lozenges. So you hold them in your mouth for 7 minutes, and then you spit it out. And then the experience with ketamine lasts about 45 minutes to an hour. Within an hour or so afterwards, you're pretty much back to normal. So it's kind of convenient that way. What was interesting to me is that, first of all, doing it in a series was a little bit like establishing a relationship with the medicine. So I did lower doses. I had an experience that felt very friendly, but I didn't get where I wanted to get. And so they increased the dose each time so that I was taking more medicine. I've since discovered that if you hold the medicine in your mouth longer, you can get more benefit from the medicine at a lower dose. But I've since seen a therapist here who does ketamine And so I have a prescription for lozenges, but I use them very rarely. My experience was tremendously helpful. Ketamine is very interesting because it's very dose dependent. So at lower doses, it's a muscle relaxant. It is good for pain, but it's not the kind of thing that you could take as a pain medication. But it's a little bit of a vacation to take medicine at the lower dose and just have a lot of relaxation. At a higher dose, you have some visuals, you have some insights. Maybe at a higher dose, it feels like those insights come from a different place, which is kind of interesting. But my experience with ketamine was, ketamine is a dissociative. So at a certain dose, you lose the sense of your physical being and you become, in a sense, disembodied. At a higher dose, you may experience ego dissolution. So I had an experience of recognizing that Robert Ellis, my personality, my ego, is a kind of a social construction. And it's hard to describe these experiences, but that was a profound experience for me because it took away my fear of death. I'm not afraid to lose Robert Ellis. And so it helped tremendously with the depression and the anxiety. There's something about ketamine, which I'm sure could be explained better than I can. It has an effect on your brain, which is, it kind of continues to work for a few days, even after you have the experience. And so I definitely felt that it helped tremendously with my existential angst. So I found it tremendously beneficial. One thing to note is that ketamine can affect your bladder. People who become addicted you can damage your bladder if you overdo ketamine. With some people who are very sensitive, you can experience some bladder issues. I seem to be one of those people, so I'm very cautious in and very sparing in my use of ketamine. There is a protocol that can help with that. So if you use ketamine and you notice that you have any kind of urinary difficulty after ketamine, it's good to use this protocol, which I've posted on the Cancer Patient Lab forum. But it was a very worthwhile experience, and I can highly recommend it for anyone who's struggling with these kinds of issues.
Thanks. Wow.
Brad, you're muted.
I'm always worried about a dog breaking in, starting to bark. Thank you, Robert. Jeff, would you share your experience with psychedelics?
Sure, I will. If you hang on a second, my dog just broke in.
Brad, I assume we'll maybe hold questions until Jeff is done.
So my experience has been,
probably it would probably be better.
Yeah.
Go ahead, Jeff.
So my experience has been microdosing with psilocybin, and I'm following a particular protocol that was recommended by Paul Stamets. The idea is to use a very small dose, which is right at the threshold of being able to feel it, and to do that for 4 days, off for 3 days, on for 4 days, and to do that for a month, and then to take a month off. So I did this after doing my own research, some consultation. And what I found is with the medication I take, which is an androgen deprivation medication, Orgovix, while I don't have hardly any side effects from it, it does affect my cognition. Things seem slower. There's a mental fog. And what I found with microdosing was that it tamped down that effect. It's those of you that have used a camera with a lens, microdosing is like bringing things into a focus. Or if you get a new pair of eyeglasses, you think everything is just fine with the ones they had, but the new ones, things are clearer and brighter. And so anyway, that's what I have experienced. And then more recently, I had the opportunity to experience I would say kind of a full dose, expertly facilitated psychedelic experience, which again, as Robert was saying, it's kind of hard to put into words, but it's a numinous experience. It really helps you be, even afterwards, in the now and present, to take pleasure in everything. And it's not something that, oh, I still feel high, or, I mean, it's just a feeling of being more alive. And with that feeling, anxiety about, my illness and, mortality, which as you get older, that's always there regardless of the illness. But with prostate cancer, it becomes more real, and okay, I have this thing and I'm likely going to die from it sooner or later. So I found both of those extremely helpful, and in particular, I would say kind of the full dose psychedelic experience was just numinous and profound. And I imagine it staying with me for, I hope, ever.
Thank you, Jeff. We'll come back and have questions for Robert and Jeff, but maybe Manish and Rebecca, you could introduce yourselves and share a bit of your research, and we'll treat this then like a kind of like a panel for the four of you. And so if you could sort of share your research insights, maybe there was something that Robert or Jeff said that you can piggyback on, whatever. And as Amit requested, if you could start by introducing yourself.
You're muted, Manish.
Sorry about that. Really appreciate you guys having us. It's bringing up a lot of emotions for me, and thinking about there's so much to say and so much already on the two shares to reflect on. I have a couple of slides I'm going to share. This is not a slideshow or presentation, but by way of introduction of why I'm doing this work, why we're doing this work, and who I am. And then rather than sort of have a lot of commentary on what's been said already, I have some thoughts on some of the things. I think it's wonderful what you guys have shared, and I'm happy to share that, but I also would really much prefer to have a dialogue and see what's on your guys' mind and who you're on, because this is exactly why we're doing what we're doing. So I'm an oncologist, and interestingly, I did not know this when I agreed to do this. I'm a prostate cancer oncologist. And so, can you guys see my slides okay?
You might want to put it on slideshow to make it a little bigger.
Let me see if I can do that here. Stop share. Sorry about that. Slide. Give me 1 second. Slideshow. Oops. If I do that, I don't know how to do both. Let's see.
That's okay.
Yeah, sorry about. Let me see if I can do it one more time, and if not, I'll just, you guys see it smaller. But
yeah, maybe you can zoom it or something.
Manish, maybe
I
can
see.
take care of
Okay,
this.
I got it. Yeah, I got it.
You got it? Okay.
How about that? Does that work?
You got to hit unshare and then share again, because we're probably seeing your old screen.
Okay. So say share, Laura.
Now share it now that you've put it into slideshow mode.
Okay. I see. Okay.
It's okay.
Got
Can you
it.
guys see that?
You got it.
Oh, that's
I
better.
did it.
You know, so I mean, this is just full circle for me. So why am I doing this? I'm a oncologist. I was at the NIH and then the NCI, and then practiced oncology for 20 years in a large group. And most of my career sort of tread mostly above the water, what I called it. And this is not new to you guys, which is traditional surgery, radiation, chemotherapy. You know, so I did lots of research in prostate cancer, did the early studies on abiraterone and Zytiga. We were an expanded access site, did vaccines. That's tons and tons of work, but also realized that so much of my own patients' lives, their quality of life was underneath the iceberg, things that we never really addressed, what I call psychospiritual issues. And over time in my own personal journey, you know, felt a sense of burnout in that even though I was helping people live longer and really taking good care of them is what I thought, but still there was so much of their experience of existential distress, the impact on their loved ones, on themselves, that were never touched. And that really wore out on me. And so that led me into starting a clinical trial using, let me see if I can. All right, this is not progressing. Led me to do a clinical trial with, sorry guys, with psilocybin in cancer patients. And I just want to, technology is not communicating. And the reason I sort of want to share this with you guys, because it is really going to speak to you guys in that, just to see the pictures, they're just really pictures of what we're doing and where we're at.
So Manish, if you keep talking, I'll load it up. I'll present it. You just keep rolling.
Okay. So, you know, so we're outside of Rockville, Maryland, in Rockville, Maryland, a cancer center, 3 floors with, you know, radiation on the first floor, chemotherapy, traditional oncology on the second, PET scanner on the 3rd floor. And in that space, we built out a center to do psychedelic research. It was really the first purpose-built center to do psychedelic research in the country. And the reason we wanted to build it in the cancer center was we wanted to communicate to cancer patients that where you go for your cancer treatment is also a place where you could go for mental health, that you shouldn't have to go somewhere else to get that, and that healthy people actually got that addressed. And so it was very deliberate to build it in the space where cancer patients come to get their care, and that is a sign of strength to do that. And then we launched a study 3 years ago that was FDA and IRB approved. It was really the first study that was been done since 2016, and we used a group format where we. Do you want to just back up to the cancer center, Laura? I think it'd be nice for people to see that. Yeah, this is what the cancer center looks like. And then can you go to the next slide? Yeah, and this is literally what our space looks like, where you come in, and the middle rooms there is where we do group therapy. So ours was a group approach. And so 4 people at a time would get psilocybin, and we would support them through their journey, and before and after they would talk about what they experienced and shared. And this room is room what it looks like. It's actually made out into a bed when somebody's having a full psilocybin journey. Laura, what's the next slide? Yeah, oh yeah. This is actually the middle pane is what somebody under a psychedelic session in our center looks like. The first one is a preparation. And then Laura, go back to the first slide around set and setting. And I'll sort of stop because I don't want to, it's already at 12:24. You know, I guess one of the things that I heard about the different ways that you guys have experienced psychedelics so far is that this is a very basic concept to sort of think about in psychedelic research and psychedelic treatment, that there's 3 things that are important there. You know, one is the drug that's taken. So whether it's ketamine or psilocybin or LSD or 5-MeO, there's methadone, there's multiple different psychedelics. and then the amount that's taken that's already been touched on, microdosing versus, a psychotherapy dose versus a mystical dose. And the setting is how it occurs. And I'm glad both of the participants here had really good experiences. And I would also say and we treat a fair number of participants in our study where, we have 3 studies open right now. People can have really hard experiences, and it's really important to have the right support. And you don't always know what's going to happen in that setting. And so how that happens can lead to a deeper and better experience. I'd say for a good, roughly, I think 60% is probably fine to do it on your, with a friend or a support, and it works out okay. But certainly people can have very difficult circumstances, and that's where sort of a bad trip occurs, where something difficult comes up and somebody's not there to support them through that, of how to be with that. And that can be re-traumatizing or more difficult. And so that's why the setting is important, and the mindset a person brings to it. So how you think about it, how you prepare for it is really important. And so the way we do it, and where the research has been, people get preparatory sessions where you're prepared to have the experience, what you might expect, what might come up, to establish a trusting relationship. And then in the session itself, you have a therapist with you the whole time, with music and eye shades. And then the next day you talk about what happened. And then a week later, you come back again to talk about it and help integrate it into your life. And it's interesting talking to this group. So our study was 8 weeks, and the data was great. It's published in JAMA. And if you want to share that, you can, Laura. But what I'll say is, so even 2 years later, people are still having a good amount of symptom relief from the treatment. Is there another slide, Laura? Now we have 3 other studies open now. One actually where we give a cancer patient and a family member MDMA both at the same time to talk about how the cancer has affected their relationship. And then we have one where we're treating a cancer patient with psilocybin, similar to our first study, and another one to treat demoralization in cancer. But what I was going to say is our first study ended at 8 weeks, but then the people that participated said, I feel like I went to war with these people. I don't want to stop meeting. And so they continue to meet once a month to talk about their experience and integrate it. And that's been a really meaningful part of their experience. So I'll stop there because I'm so excited to talk to you guys. I sometimes give talks to cancer centers and blah, 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 but this is sort of the heart of why I'm doing this. And so I would rather interact with you guys and sort of give you all the things that I can talk to you about.
Thank you, Manish. Rebecca, did you want to have something to add or introduce yourself?
Sure. And thank you, Manish, and thank you for everyone who's already spoken about their experiences. It's definitely always powerful to hear those stories. So just a little bit of background about me. I'm currently a postdoc, obviously working in psychedelic research with Manish, as well as the Center for Psychedelic and Consciousness Research at Hopkins. And so I'm involved in a few different studies. And just to kind of keep this short and sweet, one of the studies that I'm working on trying to get up and running is going to be for psychedelics in grief disorder. So I'm really interested in learning about everyone's experiences and being able to kind of carry on this conversation and, incorporate that into my own work.
Thank you. Rebecca and Manish, you didn't, you referenced the JAMA work and you flashed a slide. Can you just sort of give us a feeling of success stories? Like what's a good scenario for somebody who's gone through this and had it be very useful, just, focusing on an individual that you can, cite along those lines. And then any kind of statistics on like percentage that are yep. You said 60-40, maybe successful versus good trip versus bad trip. Anything else that just sort of gets us.
I can give you lots of data. So, and in fact, happy to share the publication with you guys. But 80% of all the participants had more than a 50% reduction in their cancer symptoms with psilocybin treatment on our study. And then 50% of the patients went into what's called a complete remission. So they were the same level of depression as someone that wasn't depressed. In other words, they weren't depressed. And the way that's done in the study is clinician administered depression scale called MADRS. And so we would measure their MADRS before they were enrolled in the study. Then we would do the preparatory session, the treatment, then the integration, and then measure the MADRS score 8 weeks later. And that's the results I'm quoting, is that 80% had more than a 50% reduction of those scores. And then half of them had no depression whatsoever. And that data persisted at 8 weeks, but also up to 2 years now.
Okay. And for both of you, one of the things is we have very engaged and activated patients, and they may hear what you're saying and say, how can I access your services? So can you kind of paint that picture?
Yeah, I mean, so Rebecca, so we're right now, we're the only center that's doing studies with cancer patients and psychedelics. There is a study that will open up in January. That'll be at 4 sites. It'll be at our site. Then there's 2 in California in the LA area, and then 1 in Northern California. So 3 in California, and then we're sort of the East Coast site. So those are the 4 above ground. I would say those are the places to access those studies right now in cancer patients.
And it would look something similar to what you described of a multi-week thing, come in, group of 4, etc.
So it's a little different. So we have 2 studies open. One, so traditionally it's been psychedelics traditionally have been done with 2 therapists and 1 patient. And so that study is open. We have that format is available, and that will be the one that will also carry forward in the 3 sites in California. Then the group format is also open at our site. And so there's 2 different ways. One is a group approach, and one is this individualized approach.
Got it. Someone asked a question about sites, like where they are.
Yeah, it was Brian. Me. Where in LA? You said the LA area. What centers or?
It'll be a UCLA.
Okay.
The Lundquist Center there. So Charlie Grob will be the PI, and if you guys are welcome to reach out to me, and I'm happy to put you in touch with investigators and things.
Okay, UCLA is great. I know Rick and I both go to UCLA.
Okay, it's the and there's really 2 sites in around the LA area. One is Lundquist, and then another one. But anyways, they're UCLA affiliated. So
okay, perfect.
In Northern California?
In Marin County, a cancer center there called Marin Cancer Center.
Thank you. And we'll use the raise hand feature now, if you would, to if you have got questions. And Amit's raised his hand. What would you like to say, Amit?
Thanks, Manish and Rebecca, for your stories, as well as Robert and Jeff. Manish, just want to clarify the statement that you were making about kind of the patients they're covering. Initially I thought I heard that their cancer actually went down, but then I thought I heard that the MADRS score or MADRS score, which measures depression, that went down. Can you clarify the effect of psychedelic on actual cancer disease versus the depression and well-being, and what are you measuring, both of them, and exactly how data adds up on that?
Yeah, so to be very clear, all the studies have been measuring the impact of psychedelics on the mental health aspect and not on the cancer itself.
Okay.
Which is the MADRS, and the reduction and all that was in people's well-being and depression scores. I think the question you're asking around, does it affect the trajectory of the cancer? That's unknown, and that's a longer arc that needs to be studied to see whether that is, but there's no study that validates that or suggests that, so I would not want you to take that away from what I'm saying.
Okay, I appreciate it. Thanks for the clarification. I mean, obviously, mental health may have side effect and role in that, but again, that's not a direct correlation or a measure of those things. So,
Absolutely right.
thanks.
Right. It's not at all.
Jeff, you have a comment, question?
Uh, um, I spent most of my career in the mental health field, and my experience was individuals who were diagnosed with a more severe mental illness like schizophrenia were never really given the chance to process what that meant. And we saw that as that diagnosis in and of itself was a traumatizing experience on top of the symptoms that maybe resulted in somebody being hospitalized. And while the symptoms of the illness were treated, the trauma of the experience of the illness and what it might mean for an individual's life, even in therapy, really wasn't addressed as a traumatic event. So I know for myself, the diagnosis of, oh, you have prostate cancer, here are the stats on this, here's what we're going to do for you, and a very unfeeling hand on the shoulder from the doctor ushering me out. And that was what it was. Yeah. So, the microdosing, the kind of the fuller, I would say kind of, numinous experience, certainly got to that piece, but I think, I guess that's my question, have any of us really had or even been offered, support for processing that piece, or have people kind of gone out on themselves? So I think the under the iceberg piece of support is crucial, and I don't think it's offered or sometimes even sought out by some of us.
Manish, Rebecca, you want to comment on that?
I think I'll say a few words, Rebecca, you should please chime in as well. I think you're 100% right. And so I think one of my messages isn't everyone should go find psychedelics because they're sort of the answer to everything. It's that the iceberg is real, and having a cancer diagnosis in anyone is going to cause an existential crisis, because it is going to bring up questions around meaning, purpose. You lose control. There's a traumatic experience of the diagnosis, the relationships, all the impacts it has, and it does have an impact, and you should seek support for that. And for some people it might be psychedelics, some people it might be therapy, some people it might be a friend, but then to know that that's a real part of that. And I think we don't do a good job at all around that. Another slide I didn't present is called collusion of denial. And so there's in a way that you go in and, you get your vitals and you go get your labs and how are you? I'm fine. And then the doctor comes in and you may talk about your symptoms, but how much are you really going to go into it at that point? So you sort of carry on that things are okay, and then everyone in the system also carries on that things are okay, but there is this iceberg that's going on that's real, and that's from the patient to the caregivers to the nurses to the doctors, not in the sense of like it's malevolent, it's just a collusion where it's more convenient almost not to process some of those things. And so I think you're 100% right that we don't bring it up, we don't talk about it, and then you're sort of left on your own to figure out how to, journey, walk through that path.
Thank you. Rebecca, anything to say?
No, just to add on to what's been said already, just really echoing that that's so incredibly important and so easy to kind of feel maybe lost in the system, and that those kind of iceberg level issues aren't properly being dealt with, and that it's just critical to get this kind of support, as Manish was saying, whether that's through psychedelics or something else. And I just am really inspired to kind of hear everyone speak to the importance of that and to be able to kind of acknowledge that out loud.
Our different groups better or worse at that? I mean, sometimes men are supposed to be kind of stoic or something and not really pretend that they've got it all under control. Are there different people that tend to be more open about admitting that they have issues in that area?
That's a tricky question. I would say that probably that's generally true. I'd say women are more in touch with their emotions than men in that aspect of it. And so sometimes, at least previously, there was a stigma around, well, I'm fine and nothing's wrong. And it wasn't sort of okay to talk about that as much. I think that's changing. And, you know, in my practice, when we were doing the studies, I was an oncologist, and then I would also talk to people about this, and they'd say, well, I don't know, like, I'm not really depressed. And then when you actually gave the scale, people were depressed. And so it was hard to, like I said, you're willing to take a cancer diagnosis, I can give you poison, kill cells to help you live longer, but then it's harder to admit that you might have emotional struggles and that might need some help around that.
Yep. Okay, Brian, you're up next.
I have lots of questions, but I'll start off with one, and this is really open to anybody. To the extent that you can talk about it, how is this experience, which is in a clinical setting, different than a non-clinical setting, particularly for those who may have experimented with psychedelics, say, in their college years? I don't know who can speak to that, but I'd love to hear some perspective.
Well, I mean, I'm talking, please jump in, but it's quite different in that this is supervised. And so typically in the college settings, we had several participants that did have experience in college, and it was like a great experience. It felt good.
Yeah.
And that was different than with this intentional mindset. So that's a lot of times it was more social. It wasn't sort of solitary and outward rather than inward. And so there wasn't sort of a preparation of, you know, why are you doing this? What's going on? Let's get to know you. And then when you actually have the session itself, you have headphones on and eye shades, and you're laying down, you're going inward the whole time, and you're exploring your psyche very deliberately. And then you come out and talk about the event. Whereas typical, quote, college experience, you're not inward the whole time with music as eye shade. So it's a very different intentional approach.
Okay.
But happy for others to say if they have other perspective on that.
I never did, psychedelics until yesterday. And so my experience was, it was kind of clinical in that I was in, an office. The doc was an ENT, emergency doc, But once I'm laying in the chair with my eyes covered and the noise canceling headphones, I could have been anywhere.
Yeah.
Didn't matter. Actually, I originally was thinking of doing it as intravenous based, and he talked me into doing it intramuscular because he felt the IV tubing makes it more clinical. You move around, you have to be careful of the tubing. You might get beeping. But I was not, I went, in terms of the psychologic, I had this yesterday. Wednesday mornings, I talked to my therapist. So it was deliberate, but it wasn't, boom, 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 one after the other.
Yes.
Which I think was a good idea, because I definitely needed time to process what I went through.
Yeah, and so I think our approach is a little different than that, because what I would say is you got ketamine treatment, not ketamine assisted therapy, and our belief, at least, is that that the more of a trusting relationship you have with the person that's sitting there, the deeper you're able to go. And we actually don't talk about it that night or even the next day. It's meant to be inward, but some part of your psyche knows safety, and to go to the darker and deeper places, or the material that you really want to get to, sometimes you need that support, and that support is built with trust, and that trust starts in the preparatory sessions and then during that time. And so in a higher dose session, so our doses of psilocybin are 25 milligrams, which is like 4 to 6 grams of dried mushroom. It's a large dose, and to go into that sort of deeper place to have a potentially unitive experience, you do need psychological support.
Just if I can comment, you know, so I tried mushrooms in college and twice, and what I found about the experience was that it was just amazing. But one of the key elements of it was the visual. You know, just the whole sensory perception of like what was going on. And so I kind of hear what Robert was saying about, you know, having the eye shades on, you could be like anywhere, maybe. But I found, you know, light and sound to be so much a part of that experience. And so it seems like that would be different to a clinical setting, but.
Okay.
Maybe not.
Oh, go ahead. I didn't raise my hand. Let other people go.
Go ahead, Jeff.
Go ahead.
Yeah, I've certainly had you know, LSD experiences in college, and my more recent experience with kind of a full, you know, numinous dose. You know, all of the, you know, those 3 aspects: the dose, the setting, the expectations, were all, I would say, kind of exquisitely facilitated. And I didn't wear an eye shade, although I rarely open my eyes. And again, this was a you know, expertly done, but it was not a psychologist or a therapist who was facilitating, and it was also done in a small group. And, you know, all of those processes and touchstones were honored. However, for me, it was the inner experience. I could open my eyes if I wanted and see what was there, and it was, you know, certainly a little bit altered. And that could be part of it, but that wasn't, you know, it was the inner experience, and having people who I knew were there could check in on me. So it felt like I was in good hands. I felt, you know, I trusted everybody, the facilitator, the setting, just the whole process. So that's what I would say was very different from my experience in college, although it was, you know, profound and it even stayed with me. This was at a much deeper level.
Thanks, Jeff.
I want to ask one more question of Rebecca and Manish, and maybe Robert would comment on this too, which is, when you've seen multiple experiences, what are the best practices that have emerged for you? Like, how have you evolved your thinking, treating the process as an experiment? What would you say are things to do, do's and don'ts?
Somebody else want to start off? I'm happy to start. I did want to say one thing on what Jeff said. I piggyback. I think that what Jeff said is very much similar to our approach, and I don't mean to. And the field is really, the medical aspect of this is evolving in terms of who the right people to sit are. So traditionally it was MD and PhDs and therapists, and now the FDA has loosened its regulations around that, and so it requires one of the people to be a master's level therapist, but then the second person can be like a chaplain or somebody with a bachelor's degree but with some mental health experience. And so it's closer to getting to, you know, the field the medical field is struggling or trying to figure out what the right qualifications for those are. And so it's not to imply that because you because you have an MD, PhD, you could be qualified. You may not be, though. You may not be good at sitting, and so the skills are different. So I just did want to clarify that. But in terms of, in each one of our studies, we sort of refine our process and try to learn more about how to do it. And so I think good practices are the ones that sort of already been touched on. One is to have some sort of preparation going in, having support during the session, because things can go sideways, and having someone that doesn't know how to navigate that and doesn't have that support isn't wise. And then having some sense afterwards to carry it on, I think, are really important aspects. So the setting and the drug is really important. And so and I encourage now people, I don't think they have to have a therapist or a counselor, but I think having some of that even before you come in allows you to have a deeper experience, because you're already thinking and grappling with some of these issues. And then the session allows you to go to such a deeper place than you could just sort of intellectually. And then coming out, if you already have that trusted relationship with someone, they can continue to help you process that. That could be a therapist or a friend or a counselor, but I think it's important to have those practices in place. And a meditation practice, I think, is also really important to have, to be able to be introspective and be with your feelings and knowing what's coming up. That's a good skill to have outside of it, but in the session itself. Because one of the things that we teach you is to go in and just observe what's happening and just to take it in. It's to trust, let go, to be open to what's occurring. So it's like your mind, your consciousness is teaching you, it's showing you things, so just take what's there. And that's a skill that can be learned more easily with meditation. But I'd love to hear what other people think is good practice.
I'll use that as a segue for you, Robert, since
Hey,
oh,
Brad, sorry, this is Amit. I'm driving and I don't know who has raised hands, or I do have a question and then I need to drop for my radiation treatment. May I?
yes, go ahead.
Dr. Agrawal, can you speak of the negative experiences? You obviously shared statistics of, successful experiences and stuff. What's did a person come in and they were generally okay, may not be perfect, and kind of left with, feeling worst after this? Can you talk about any, you mentioned, not a good experience, but what's the true downside, or what kind of stuff can happen on the negative side?
Yeah, so I mean, so people can have difficult experiences in the session itself. So first, we would, in our study, you had to have some degree of depression to come onto the study. But then, people have described here sort of a unitive experience or an ego dissolution. But for others, it can be literally a dying experience. So one of our participants, she felt like she was dying, and it was difficult physically the whole time. She was thirsty and nauseous and literally like a dying experience. Another one had fear come up. And so, and other times people expect that they're going to deal with their cancer, and it ends up being about their childhood or relationships with their parents or trauma that they didn't even know about. Sometimes they had a repressed memory and they didn't know that it was going to happen. And so sometimes people go in expecting to have this unitive experience, and it's a difficult experience, and they feel emotional turmoil. And I would say being able to be with that and have the support to come through that usually ends up making people feel much better, but it's a longer arc than just the session itself. And if that isn't properly supported, you can get stuck in that cycle. You can get stuck in that place.
That's really valuable. I think you're really giving us thought of this as not being an event, but being sort of a process, a journey with a lot longer time horizon. And that's an important insight. we've got 3 hands up and 5 more minutes. So we'll kind of do it rapid here. Robert, you're up next.
Yeah, just a quick question. For anyone who might be thinking about doing this on their own, integration is a really important part. How do you process this and integrate it? So because you have, I'm sure, a lot of experience with this, I just wonder if you could comment on best practices for how to process and integrate the experience afterward.
Yeah, I mean, so I would say like there's immediate integration, which happens in the next few days, but there's lifelong integration. And so we recommend people to go out in nature to do art and other non sort of left-brained activities, because things you're trying to access are not necessarily in that part of the psyche. And then it doesn't have to be a therapist, it could be a counselor, but sort of a wiser person that's been down some of this path, that's done some of their work, can also be help integration. And then there are other books and tools, because things now will make sense that may not have previously made sense to you, whether it's religious books or philosophical books or ways of thinking about dying and about life that were sort of concepts in your brain, but now actually can make sense to you in some ways. And so it's a big topic. I think integration is huge. There's such a focus on the experience itself, but I think what you're describing is what's going to lead to a long-term and lasting change. It's not a quick magic bullet. You take it and you're done, and the integration is key.
Thank you. Bob Gurmankin.
Yeah. So I know you said, you have some patients who get into a dark place. Do you recommend, like it was recommended to me by Robert, to come into the session with some questions as opposed to just opening up my mind to whatever happens? Is that something you recommend for the patients you see so that they can, at least to a certain extent, direct their experience?
We say it both ways. We always have someone work on an intention of why they're doing this. And so we do have people come with intentions, but then we ask them to hold it lightly. And partly what we're trying to do is get you in touch with that there's an inner healer, there's an inner psyche part of you that knows what you need, and you need to tap into that. And so that I tell people is, if you could have solved this, you're all smart people, you would have solved it. So it's not thinking your left brain that's going to solve this. There's another part of your psyche that you're trying to access. And so to trust that. And so some of it is letting go of this mental fixing and solving and figuring it out. And so that's letting emerge what happens, at the same time having an intention.
Yeah. One thing I always thought of, in terms of depression is, if you've got a good reason to be depressed, such as terminal cancer diagnosis, well, that's not depression. You've got a good reason. But I think I've realized that that's still depression. Even in, it doesn't matter whether there's a good reason to be depressed or a bad reason to be depressed or no reason. Depression's depression. And is that kind of your feelings?
Yeah, I think that we've done a disservice by pathologizing depression. Your body is just feeling, you might be feeling sad, and it's a normal response to things that are happening to you. There's nothing wrong with you. Something is just telling you that something isn't right, and you're trying to sort through that. It's your body. It's like when you get a fever, when you have an infection. It's not that something's wrong. So depression is it's a healthy response to maybe a difficult circumstance or different things that happen to you. So I don't pathologize that.
Thanks, Rick.
Yeah, thanks so much. I've really learned a lot. And for me, I think accessing peace is what I hunger for. So whether it be through my faith and just acceptance or being calm, I think I have a ways to go in my journey towards peace. I would like to, be as happy and peaceful as I can for the days I have left. And I want to really thank Jeff and Robert, Rebecca, Manish. Thank you so much. So I thought about, this avenue towards peace, but I haven't done anything. And I think it's really interesting. And so I'm quite open to seeing what I could do. I'm in a band. And what do bandmates give you? Here, take some of these I don't even know what it is. My keyboard player gave me some, I don't know, microdose gummies or something like that. So it was like kind of, you can see they're unopened. And it was like going, huh. So I don't know whether, to try that doesn't seem like a good way to approach this, but I thought about it. In college, we took a bunch of mushrooms and went and saw Alien. Okay, that we did not like kick back. We saw Alien, me and my two roommates, and jugglers are juggling things on flames, and I'm stealing trails, and it was just wonderful. And the movie was so good, except for me and Stan had a great time, but Dennis had a bad trip, and he went into the bathroom. He goes, I gotta go to the bathroom. It's like, okay. So after about 10 minutes, we go, where's Dennis? So we had to go to the bathroom and drag him out, so it really showed that, you could have a bad trip. Maybe this plan isn't the best plan. So any comments? Or I think peace is what I'm looking for. I don't know. I'm ready to listen.
I think generally, I'm glad you're looking for peace. I think many people are, and it's wise. I would generally recommend not taking a substance unless you know what it is and how much it is and what all it contains, especially a psychedelic substance, without some sort of support.
Okay, I have treatments at UCLA, so maybe I can hop in.
Yeah, those studies are getting activated literally now, and they'll be up and running by the end of the year, beginning of January. They're excellent people. It's free.
No.
If you're in the area, you might as well just avail yourself to that. So
my neighbor, microdoses. This is a very conservative person. I was like, well, what? It's a 60-year-old housewife is microdosing. I was like, well, what's it? And oh yeah, I love it. Have you heard of microdosing? And is that something that's safer, or just grab some of her stuff? Or it's kind of counter to what you just said. So I would say don't take that plan, I guess.
There's lots to say about it. I know we're almost at time, but microdosing is it's a much lower dose. It's not been medically studied as much. There's studies that are now launching around that. So like if a full dose of psilocybin is 25 milligrams and a microdose is considered a tenth of that, it's like 2.5 or less. And it's not been formally studied. And so it's hard to make a lot of medical comments on that. But there has been literature written about it, as people have already suggested. Paul Stamets has one, and then he's just blanking his name, but people do it, and there's literature out there on it, and so I would do some research on it.
Thank you again, everyone.
Manish, Rebecca, how are you set for time? Because as Manish just pointed out, we're past the hour.
I've got another meeting coming up. If there's something quick we could probably do, and I'm happy to come back another time and
okay,
have a conversation.
Let me suggest that everybody who needs to leave leaves now. I'll stop the recording, and we can those who want to continue to discuss and have time can stay.
And so I do need